Our next speaker is Dwight Koeberl, and Dwight's going to talk to us about using liver-directed gene expression to induce or modulate immunogenicity.
Thank you. So we've coined a term over the years, immunomodulatory gene therapy, or IGT, for this talk. And I'm going to define it, talk about designing vectors for this, demonstrating immune tolerance after vector administration. I'll talk about development of IGT in detail in Pompe disease, and then immune tolerance induction with IGT in hemophilia and Pompe, and then the potential demonstration of that in clinical trials. So we could say that IGT will suppress an immune response that would otherwise interfere with efficacy, and examples include making a protein therapy effective, suppressing transgene-directed immunity, suppressing a pre-existing immunity in recent work. And so IGT suppresses immunity against the transgene product, not the vector particle. And this is an example of a vector that we've used extensively. It has a liver-specific promoter, a synthetic promoter, to drive liver-specific expression that suppresses immune responses. And it's capable of immune tolerance induction, or ITI. And formal testing to demonstrate ITI is important. So there are two basic types: an immune challenge, where you would introduce the transgene product with adjuvant to the vector-treated animal, then monitor for immune responses. And prevention of antibody formation in that setting confirms ITI. And then adoptive transfer experiments are a little bit more involved, isolating splenocytes and administering those to a recipient, doing an immune challenge to the recipient, and then prevention of antibody formation confirms ITI. So it's more than just the absence of antibodies following vector administration. This is an example of the immune challenge. So mice that are challenged with the antigen, therapeutic protein, are then challenged again with the antigen plus adjuvant, and in that setting we'll see immunity antibody formation. Whereas if we give the AAV vector to induce immune tolerance and then challenge with antigen plus adjuvant, we won't see antibody formation. Then adoptive transfer, and this is an example, an experiment where we administered a vector that would normally provoke antibody formation against the therapeutic protein GAA. And in the wild-type mouse, we can see that isolating the CD4 positive T cells and administering to a wild-type recipient, then that recipient will have an immune response against an immune challenge here. For the MyD88 knockout mouse that has a defect in innate immunity, we give that same immunogenic vector, isolate CD4 positive T cells, administer to the wild-type recipient, and even though we give an immune challenge with therapeutic protein, we don't see an antibody response. So shows the very important role of MyD88. This is an example then of both experiments, group from the Genzyme group led by Robin Ziegler. And so they had their vector, AAV8 vector, containing their favorite liver-specific promoter, DC190. And so for the Fabry mice treated with that vector, and then an immune challenge with alpha-gal plus adjuvant was given, mice that received the LSP containing vector didn't form antibodies, whereas those that received a vector containing the CMV promoter did form antibodies after that same immune challenge. Then the adoptive transfer experiment, recipients that received the splenocytes, the CD4 positive T cells from mice that previously treated with the CMV containing promoter did form antibodies, whereas those that received the splenocytes from the mouse treated with the LSP containing vector didn't form antibodies, demonstrating immune tolerance with the LSP containing vector. I'm going to talk in detail about implementation of IGT in Pompe disease. So this is our disease model where there's deficiency of acid alpha-glucosidase, a lysosomal hydrolase, and it causes accumulation of glycogen in the lysosomes, lysosomal dysfunction, and muscle weakness. So there is a standard of care therapy developed by Y.T. Chen and colleagues at Duke, injecting the recombinant human GAA periodically. It's taken up at the mannose-6-phosphate receptor at muscle and then trafficked to lysosomes where it's activated and it can clear glycogen. But we know there are limitations to this therapy, and those include any factor that would reduce the benefit. So those include late treatment, the degree of accumulated damage, and defective autophagy that's seen in a subset of patients, as well as the focus for today, patients with high sustained antibody titers. So this is an example of the problem. Actually, so there are cross-reacting immune material or CRIM-positive patients, and they have mutations that result in residual enzyme that would be, have defective function because they have Pompe disease. But that residual enzyme is sufficient for the immune system to recognize GAA itself. And so during ERT, there would be low antibody formation. A few patients have higher antibody formation. But with the low antibody formation, there's a good clinical outcome. This contrasts with CRIM-negative subjects who have two deleterious or null mutations. They make no residual GAA protein, and their immune system doesn't recognize ERT as self, and there's a high persistent antibody formation that interferes uniformly with the response to ERT. And sorry, there's this a little bit off here in labeling, but this is the CRIM-positive patient with a fibroblast that have an abnormally folded GAA, but they do have residual GAA expression, whereas these CRIM-negative patients don't in their fibroblasts. The result of this CRIM-negative status is a poor clinical outcome looking at long-term results from ERT. So you can see the survival curve with the dotted line for CRIM-negative patients and with mortality, whereas the solid red line for CRIM-positive patients is clearly better. The antibody formation is much higher for the CRIM-negative subjects, reaching a median of over 400,000 inverse titer by week 64, and in contrast for CRIM-positive subjects overall, a low titer of 300. On the other hand, there are a few patients in the CRIM-positive group that still form fairly high antibody titers that would be clinically relevant of 51,200. If we were to contrast then ERT with a successful gene therapy, ERT is known to not completely reverse the disease symptoms of Pompe disease. There's residual respiratory insufficiency, gait abnormalities, patients succumb, and in a subset of those patients there are high titer antibodies that interfere with the uptake of GAA. And there's a need for a repeat and inconvenient and expensive treatment here with ERT. With gene therapy, preclinical data show that we can achieve a continuous GAA production, correct the GAA deficiency throughout the muscle, prevent anti-GAA antibodies, and actually suppress pre-existing antibodies in recent work. The promoter plays a key role in mediating these immune responses, and so a CB promoter that contains a CMV enhancer will provoke both Th2 and Th1 immune responses in our mouse with Pompe disease. That's a knockout mouse, so they're similar to the CRIM-negative patients with regard to immune response. And that vector wouldn't achieve efficacy. It would actually be eliminated from the liver due to T-cell responses. Now switching to a muscle-specific promoter, we can see that the CTL is avoided, but there's still antibody responses. So we see correction of only of the transduced muscle fibers. Whereas with the LSP-containing vector, we see absence of Th1 or Th2 responses, immune tolerance, and then prolonged systemic correction. So we've compared and contrasted results with these two vectors over the years, multiple studies. As mentioned, the CB-containing vector actually activates immunity. It's immunogenic, and the LSP-containing vector evades that immunity. It's tolerogenic. What are the data? So if we look at the short-term presence of GAA, the GAA precursor in plasma over the first days following vector administration, we see a nice production for either the CB or LSP-containing vector, but then a dropout for the CB-containing vector at day 14 that corresponds with anti-GAA IgG1 formation. And we can see for the long term continued production with the LSP, but a lack of production of GA into the plasma for the CB-containing vector, and only the CB-containing vector provokes anti-GA antibodies for the long term, 12 to 24 weeks. Then we can see T-cell response, activated T-cells with the gamma interferon response in the LE spot that's significant only for the CB-containing vector. This also correlated with CD8 positive, CD4 positive cells in the liver. So this is the state-of-the-art schematic for the immune response to liver-specific expression with an AAV vector that Roland showed just a minute ago. And there are key players here, the IL-10 production in the liver, the regulatory T cells, Tregs that are activated, they're antigen-specific, and they suppress both the activation of CD8 cells, CD8 T cells, and B cells. And then we've looked at some of the other cell types in this diagram, so dendritic cells and others, and this is a summary of data. We found that the CB-containing vector does transduce dendritic cells to produce GAA, whereas the LSP does not produce GAA in dendritic cells. CB stimulated interferon gamma in the liver that was mediated by MyDD8, and there was a prolonged antibody and CTL response to the CB8 containing vector. And in contrast, for the LSP, we saw a lack of these responses that correlated with the failure to transduce and express GA in dendritic cells. So this is our working model where through some mechanisms, some of the mechanisms remain to be defined, a vector goes to the liver expressing GA with highly there to activate antigen-specific Tregs, and these go to other lymphoid tissues to suppress immune responses, both antibody and CTL responses. We know that Tregs are important, having performed an experiment to deplete Tregs with an anti-CD25 antibody. So if the mice received our tolerogenic vector followed by anti-CD25, they did form antibodies against GAA, whereas the mice that received the vector and had intact Tregs didn't form antibodies, and they're mainly IgG1. This experiment looked at the combination of ERT with AAV, and there were 4 groups, either mock-treated controls, ERT-only mice, AAV only at a low dose, or AAV followed by ERT. So after this treatment, we did the immune challenge. We found a robust antibody response for the ERT-only mice that was largely suppressed by AAV administration. These mice that received only ERT had hypersensitivity responses, and they had mortality, whereas mice pretreated with AAV did well. And then we could see an efficacy in terms of clearance of glycogen in the muscle. And this was low-dose AAV, so there was a much enhanced response by adding ERT in the face of immune tolerance, clearing the glycogen from the heart and from individual fibers in the diaphragm. Then we're developing this in terms of a clinical therapy. So this single dose of an AAV cross-packaged vector would go to the liver, express GA specifically there, suppress antibody responses. GA will be secreted and circulate to be taken up by the heart and skeletal muscles and to treat Pompe disease potentially more effectively than ERT. This is a head-to-head comparison of the effects in blood. So we see a continuous expression of GAA from the AAV vector at a low dose, 8E11 vector genomes per kilogram. Due to the short half-life of ERT, a lack of GA activity in the blood for ERT mice, and then we can see antibody formation, again the IgG1, only in response to ERT, not in response to AAV by itself. There's a little more detail on the biochemical correction, the efficacy in that experiment. First of all, we did see some mortality in the ERT mice related to hypersensitivity, and then we can look at GA activity in the muscles and glycogen content in the muscle. We did see elevated GAA activity in liver with either treatment, in heart, a unique elevation in the quadriceps for the AAV-treated mice, and then looking over at the decreased glycogen content that correlates with treatment of Pompe disease, a very nice reduction of glycogen content in the heart. That's the most responsive muscle tissue. But a unique reduction, very nice reduction of glycogen content in the quadriceps with gene therapy that wasn't seen for ERT. We've gone ahead to do experiment to find a minimal effective dose, and so these are 3 lower doses. We've layered on ERT in this experiment to understand the interaction that we might see in a clinical trial, and it's a 2-month experiment. We saw, now this is a little bit busy, but these gray bars are mice that received ERT with varying doses of the AAV vector, and these white bars are mice that received the AAV vector alone. So we can see with ERT a very nice correction of glycogen content, but with these low dosages of the AAV vector, also some reduction of glycogen content in the heart. Similarly in the diaphragm, so the 2 higher doses here do correct glycogen content in the diaphragm. And then in the muscle, an interesting interaction where only the combination of ERT plus low-dose gene therapy actually significantly decreased glycogen content in the quadriceps, the skeletal muscle again being more resistant to GA replacement. And we'd say our minimum effective dose for biochemical correction is 8 × 10 to the 10th vector genomes per kilogram. And it's a little bit interesting because to prevent antibody formation in response to ERT, we needed the slightly higher dose, 2 × 10 to the 11th vector genomes per kilogram. And this corresponds to experiments done by Roland Herzog and others, this critical dose of greater than 8 × 10 to the 10th vector genomes per kilogram to prevent the immune response to the therapeutic protein. But we do get biochemical correction at the lower dose from the vector by itself. And we saw generally reduced toxicity at least with respect to immune response by adding the AAV vector in advance of ERT. One side note, again, the promoter choice is important, so we've done experiments with a highly active muscle-specific promoter, and we see about a 20-fold higher dose requirement for either the minimum effective dose or a highly effective dose. This probably has to do with the need to give higher vector dosages to reach the muscle, but also the antibody response that we see with muscle-specific expression that would interfere with cross-correction of untransduced muscle fibers. And then for high dose, so-called high dose, 2 × 10 to the 12th vector genomes per kilogram, and then following the mice for 30 weeks, we'd see a very nice correction of glycogen content across the muscles, greater than 50% in each. And then we saw an improved function. These mice with Pompe disease start to have decreased rotor rod performance after about 6 months of age. So we can see improvement in terms of the change for the rotor rod over time, having given the gene therapy in comparison with the untreated animals. This would be an acceptable dose for a phase 1 clinical trial. 2 × 10 to the 12th vector genomes per kilogram has been administered in multiple trials already. Here's our plan then. Some details. There'd be 2 dose cohorts advancing from an effective dose from preclinical experiments to a higher dose. Safety being the main endpoint with some measurements for efficacy. So bioactivity in terms of GA activity in a muscle biopsy performed at baseline and then after vector administration. GA activity in plasma. We wouldn't see elevated GA activity in plasma from ERT that will continue through the trial because of the short half-life of enzyme in blood. Then muscle function testing, a urinary biomarker. And this is a single site study to initiate this fall at Duke University. I want to show several other examples now of what could be termed immune tolerance induction of eliminating pre-existing antibodies. So switching to hemophilia, we've heard a lot about at this meeting, but it's a great disease to study. Factor VIII deficiency in hemophilia A, factor IX in hemophilia B, and importantly, there's a high risk for inhibitor antibodies. So about 3 to 5% of patients with hemophilia B will form antibodies against the replacement factor, and a slightly higher fraction of patients with hemophilia A will have inhibitor antibodies that prevents the response to the factor VIII replacement. So this is a dog experiment from Baldur Aruta's laboratory, Roland showed earlier. And so this dog Wembley had previously been treated with factor VIII and had preformed inhibitor antibodies. the dog was administered the AAV vector containing a liver-specific promoter, and there was an anamnestic response where briefly the antibodies rose to higher levels and then they dropped to baseline, and that persisted through a factor VIII immune challenge. Then looking at the factor VIII antigen, after about a year, actually the antigen and the activity for factor VIII increased into a therapeutic range above 5% of normal. So there was a delayed response, but as the antibodies were suppressed, then there was an expression of therapeutic factor VIII. And this actually goes out longer than the published study to really show this rebound effect. Roland's lab did some studies of ITI in hemophilia B mice with an AAV-mediated vector, and the design was first to provoke antibodies with factor IX protein administration over 6 weeks, then give the AAV-mediated vector to induce immune tolerance, and then re-challenge with factor IX. So you can see by 3 different measurements that these pre-existing factor IX antibodies were suppressed, and that was despite the repeat factor IX challenge here. Then we see an increase, as the antibodies dropped, increase in factor IX antigen and correction of bleeding and uniform survival. So these mice, like the Pompe disease mice, will have hypersensitivity when challenged with the therapeutic protein, and that was prevented. This is the adoptive transfer experiment. Very nice seeing a dose increase. So groups of mice were treated with 3 different dosages of the AAV. There's a cutoff here for immune tolerance induction at greater than 2 times 10 to the 9th or 8 times 10 to the 10th vector genomes per kilogram, similar to our experiment in Pompe mice. And this shows that higher vector doses associated with higher levels of hepatic gene expression are more likely to induce a robust Treg response and induce immune tolerance. Here's another example, now a dog with hemophilia B from Baldur Ruta's laboratory. And so apparently this dog was included in an AAV experiment and had been treated with replacement factor IX previously, I think unbeknownst to the investigators. But we see the anamnestic response and then a suppression of the anti-factor IX antibodies and then a rebound of the antigen and the factor IX activity. Very high activity relative to antigen because this is the factor IX padwa that has a naturally occurring activating mutation. What was going on then in that dog Wiley? Initially, there were pre-existing pro-inflammatory responses with IL-6 and other pro-inflammatory cytokines. The AAV vector is administered. There's high-level liver-specific expression, induction of pro-tolerogenic APCs, induction of antigen-specific induced Tregs, and then we could see a decrease in IL-6. The orange line goes down as the factor IX increases and reaches a therapeutic range. We performed a similar experiment in Pompe disease mice. So group 1 is just repeated doses of ERT. We didn't go past 3 doses because that's when we start to see the hard to manage hypersensitivity here. And in group 2, we gave ERT, then AAV to model a clinical situation where a patient is first treated with some ERT and then receives gene therapy. And we followed with further immune challenges following AAV at 5 weeks. Group 3 was ERT twice and repeated twice after 15 weeks, and then finally giving the AAV at week 25 to test for suppressing pre-existing immunity. And if we look at the time course here, we can see that group 3 had formed very high anti-GA antibodies, and those were suppressed by giving the AAV vector at week 25. Despite the immune challenge at week 31, those antibodies were suppressed to baseline, whereas mice treated previously only with ERT in group 1 had some antibody formation that increased markedly after the immune challenge. So showing ITI after pre-existing immunity to ERT. Those mice also had biochemical correction, decreased glycogen across the muscles, either with early or later AAV administration, and you could see how the glycogen came down in comparison with untreated animals in the heart, diaphragm, quadriceps, EDL, and soleus, all these skeletal muscles that are largely resistant to ERT. So the immune tolerance induction correlated with a better biochemical correction. So to summarize this data, really liver-specific expression has induced immune tolerance to a transgene product in multiple experiments. We know something about the mechanism involving regulatory T cells that are antigen-specific, and what's newer is that we can suppress pre-existing high-titer antibodies. I wanted to move on just a little bit longer with something a little bit speculative, but we can look to clinical trials now to think about IgT and whether immune tolerance is being maintained. So for the hemophilia A clinical trial recently published in New England Journal with the dose escalation, this involved a B-deleted factor VIII because the very large factor VIII protein can't be, the cDNA won't fit within the constraints of an AAV vector. So during activation, the B domain is normally deleted, and this is a strategy then for building a vector, including only the A and C domains with the linker, and this was driven by a liver-specific promoter. So we can see the result then, a median correction of 100% of factor VIII activity over a year, and we'd note that there were no neutralizing antibodies to factor VIII in this population that has a very real risk of inhibitor antibody formation. To conclude then, so IgT has induced immune tolerance to secreted protein in several models. Typically there's a liver-specific promoter involved. I think it's required. Formal testing is needed to confirm immune tolerance, not just the absence of antibodies, but immune challenge, adaptive transfer. And we can now suppress previous immunity. Clinical trials suggest that IgT may function in humans as well. I wanted to just mention resources and colleagues and also vector production from Actis Therapeutics. Thank you.
Dwight, really beautiful work, and again, we have time for a few questions. I'd love to start off. So Dwight, I always think of inhibitor antibodies as being derived from long-lived plasma cells. So it's really remarkable to see that you're able to eradicate a response like that. And I'm curious if you have thoughts about that mechanism. Does that imply that there's de novo production of long-term plasma cells in inhibitor patients, or is it something about the turnover of those in that particular clinical context?
So I think it's probably the latter. You could see the slow onset of immune suppression, especially in the hemophilia experiments. But it is very interesting to think about, those plasma cells that produce most of the antibodies in the long-term situation actually being suppressed. I mean, there's more to it than, say, just producing enough antigen to swamp the circulating antibodies, because plasma cells are tremendously efficient at producing antibodies.
Thanks. A question, Carol?
Beautiful work. I just have a question on that last AAV5 factor VIII study. I can't remember. Are those patients pre-screened with the factor VIII antibody? Are these patients inhibitor negative, or?
Yeah, I believe they are inhibitor negative.
Okay, so they're being pre-exposed by factor VIII protein, but they're inhibitor negative.
I would say it's definitely something to to watch in these clinical trials going forward. I think if we use the wrong vector, we could provoke antibodies possibly in many patients. So maybe I should be a little bit more cautious in saying that we're seeing it in clinical practice yet, in clinical trials.
I actually have one final question for you, Dwight. Yep. So how long, what kind of a delay can you have between the initiation of IgT and depletion of Tregs? In other words, if you deplete Tregs at any point after IgT, will you then recover the immune responses that you observed initially?
We've only done the experiment where we waited several weeks, but there definitely is work that shows the need for long-term Treg stimulation to suppress immunity, and Roland can speak to that.
Part of what Dwight showed earlier, if you allow tolerance to be established with hepatic gene transfer and then deplete the Treg, the response comes back. And as you allow the Treg to repopulate, the response goes down again. So they need to be there all the time.
Thank you. And continuing the Treg theme, oh, sorry.
Yeah, we have 8 seconds.
Any further questions?
No. Thank you.
Yeah, absolutely. Thanks, Dwight.